To some providers, the gynecologic history of a pregnant patient seems irrelevant. It is not. In fact, it contains important risk factors that can completely change how a pregnancy is evaluated and managed. Information that may seem routine at first can provide critical clues about complications that may affect both the mother and the baby. This is why a thorough gynecologic history should never be overlooked when assessing a pregnant patient. First, consider birth control history. One of the most important questions to ask is whether an intrauterine device, or IUD, was in place when the patient conceived. If the answer is yes, the pregnancy is automatically considered high risk. An IUD that remains in place during pregnancy is associated with several significant complications. These include an increased risk of miscarriage, preterm delivery, chorioamnionitis, and placental abruption. Because of these risks, it is essential to identify this history early. In many cases, the IUD will not be removed until after delivery. That means the presence of the device continues to be an important factor throughout the pregnancy. Ask the question. Make sure the answer is documented clearly. If an IUD was present at conception, communicate that information to the receiving facility so they are aware of the additional risks involved. Second, obtain a menstrual history. Ask whether the patient's menstrual cycles are usually regular or irregular. Determine whether she missed periods and whether that is something that commonly happens for her. These details are important because many pregnancy calculations rely on the date of the last menstrual period, often referred to as the LMP. When a patient has irregular cycles, dating a pregnancy based solely on the LMP becomes much less reliable. As a result, she may be further along in the pregnancy than she believes, or she may be earlier in the pregnancy than expected. Either possibility can affect clinical decision-making and influence how symptoms are interpreted. A simple question about menstrual patterns can therefore provide valuable context and help avoid incorrect assumptions about gestational age. Third, ask about gynecologic surgery. Previous procedures involving the cervix can have important implications during pregnancy. Examples include a cone biopsy or a LEEP procedure performed for cervical dysplasia or cervical cancer. These procedures can alter the shape, structure, and thickness of the cervix. As a result, the cervix may be less capable of remaining closed throughout the pregnancy. This condition can contribute to cervical insufficiency and increase the risk of preterm labor. Because of this risk, patients with a history of cervical surgery deserve careful attention when they report symptoms such as contractions, pelvic pressure, or other concerns related to early labor. Some patients with cervical insufficiency may have undergone placement of a cerclage. A cerclage is a surgical stitch placed around the cervix to help keep it closed during pregnancy. If a patient tells you that she has a cerclage, that information is extremely important. It immediately identifies her as someone with an increased risk for preterm delivery. In these patients, bleeding or contractions should never be dismissed as minor complaints. They must be treated as potential emergencies because they may indicate that the pregnancy is at risk. Always ask about a cerclage when discussing surgical history, and always document its presence if one has been placed. Surgery involving the vagina can also be significant. Normally, the vaginal walls are flexible and capable of stretching during delivery. However, previous surgery can result in scar tissue formation. Scarred tissue may become less pliable and less able to stretch normally. This creates a greater risk of internal lacerations during childbirth. These injuries can lead to substantial bleeding. What makes this particularly concerning is that the hemorrhage may not be immediately obvious. A patient can lose a significant amount of blood internally before clear signs become apparent. In some cases, the problem may not be recognized until the patient becomes hypotensive. For that reason, a history of vaginal surgery should always be considered when evaluating potential delivery complications. Fourth, ask about specific gynecologic conditions. Ovarian cysts are one example. If a patient in her first trimester presents with lower abdominal pain, the presence of an ovarian cyst can complicate the assessment. The pain could be related to the cyst itself. However, it may also be associated with other serious conditions. Questions arise regarding whether the symptoms are due to the cyst, an ectopic pregnancy, or a threatened abortion. Understanding that an ovarian cyst exists does not provide all the answers, but it does add an important piece to the overall clinical picture and can help guide further evaluation. Another condition to ask about is endometriosis. Endometriosis is known to cause fertility challenges, and it may be one of the reasons a patient required in vitro fertilization, or IVF, to achieve pregnancy. This history is important because it provides additional context regarding the pregnancy and the circumstances surrounding conception. Endometriosis may also be associated with abnormal placental implantation, making it another relevant part of the gynecologic history that should not be overlooked during assessment. Finally, ask about active sexually transmitted infections. These infections are not only a concern for the mother, they can also have serious consequences for the baby. Gonorrhea and chlamydia can be transmitted during passage through the birth canal and may infect a newborn's eyes. This can result in ophthalmia neonatorum, a condition that can lead to permanent blindness if not properly addressed. Herpes is another major concern because it can spread to the newborn and cause devastating illness. HIV and syphilis each have their own important perinatal management protocols and considerations. Because these infections can directly affect neonatal outcomes, it is essential to ask about them rather than assuming the information has already been collected elsewhere. The key point is simple. A gynecologic history is not separate from pregnancy care. It is an important part of understanding the risks that may be present during the pregnancy and during delivery. Questions about birth control history, menstrual patterns, previous surgeries, gynecologic conditions, and active sexually transmitted infections can reveal information that significantly changes the overall assessment. Ask the questions carefully, document the answers accurately, and never assume that someone else has already gathered or communicated this information.